But today we're back to the more serious work of, at the moment, in this case, smoking cessation is what I'm going to discuss. I think this is a wonderful opportunity for practice nurses. The fact is that smoking is the single greatest preventable cause of death and illness amongst our patients. And most of the smokers in our community want to quit, and most of them will try repeatedly to quit. About 40% try every year to make a quit attempt. But the problem is that nicotine dependence is an addiction. It's not a choice, and we see it in those terms these days. And quitting is not something that most smokers are able to do easily, as you well know. In fact, cold turkey quit attempts have a success rate of 1 in 25. So if people go and do it on their own, they have roughly a 1 in 25 chance of success. Now, we can do a lot to improve on those rates, and we know from research that nurses can have a significant impact on those smoking quit rates. And there's a Cochrane review and some other research currently being done in Sydney and Melbourne which verifies that. So this is a wonderful opportunity for practice nurses to make an impact. So to help you with that, the College of GPs has developed the Australian guidelines for smoking cessation. These have been developed for all health professionals. The original guidelines in 2004 were just for GPs, but these are specifically targeted at all health professionals. They're endorsed by APNA and they're appropriate for use by practice nurses. And they can be downloaded from the College of GP website, or you can order a hard copy as well through that website. They were developed by a content advisory group, which is a panel of experts who also took input from other organisations and other experts. So they represent the current best practice in smoking cessation in Australia. The guidelines are based on the 5 A's that Marion's talked about. I'll discuss that in a little bit more detail shortly. But the 5 A's is a very important and very useful framework for changing behaviour of all different kinds. Again, as Marion referred to, they're based on recognising initially the readiness of a smoker to change their behaviour. Not all smokers are ready right now to quit, and our intervention should be based on their current state of readiness. And they recognise that the best interventions are a combination of pharmacotherapy, that's stop smoking medication, as well as behavioural change. So the combination will give you the best possible results. This is the list of contents of the guidelines, and as you can see, they're fairly comprehensive. They consist of background information and the role of health professionals, an understanding of nicotine addiction, which is the key issue with smoking. There's a series of strategies that can be used, information about relapse, and there's an emphasis on certain high-risk groups, such as Indigenous smokers and smokers with high smoking rates, smokers with mental health disorders, prisoners, lower socioeconomic groups, the high risk and high smoking rate groups, and with special information about those groups because we really need to target them. What I'm going to talk about in more detail now is the 5 A's and the operationalisation of this guidelines using the 5 A's, and just a little bit about pharmacotherapy. So just going through the 5 A's in relation to smoking cessation. The first A, of course, is that we must ask all our patients regularly if they smoke and if they still smoke. And if they're not smoking, when did they quit? Often it's been quite recent, so we need to know that. And then we take a brief smoking history. So just a few simple questions like how many cigarettes do you smoke a day, and when was the last time you tried to quit up, and what methods have you used, and why did you relapse? So simple things like that are useful background. So, and we should do that repeatedly, and we should document that information in the medical record so it's constantly up to date.
Do you find that people underreport their smoking?
Oh, definitely, yeah.
Drinkers do also?
Yes, there's definitely. There's a well-documented rate of underreporting, and you certainly need to be suspicious of that. It's the same with alcohol, and the number of cigarettes is nearly always underestimated. The second stage of the 5As is assessment. And there's a couple of key issues here. The first is the readiness of smokers to quit. Although most smokers want to quit, that's quite a distinct issue from being ready to quit. And ready to quit refers to being ready in the next 30 days to make a serious quit attempt. But the three categories you can see here are those who are just not ready at all. They're just not interested in quitting. They're happy being smokers. They may well be in denial, but they really don't want to know about it. The second group is those who are ambivalent about their smoking. They, on the one hand, are concerned. On the other hand, they have their barriers. They're worried about weight gain or stress or something. And then there's the ready group for whom the benefits of quitting outweigh the benefits of smoking. So we ask, the question that's recommended in the guidelines is, how do you feel about your smoking, which is a non-confrontational way of assessing where they're at right now. And then there'll often be a dialogue, and then you may ask, well, are you ready to quit right now? So it's important that the question is not confrontational. It's not an authoritative, directive statement, but rather, tell me how you feel, where are you at, and then you work with that. The second thing we assess is nicotine dependence. Nicotine dependence is best assessed with one simple question, that the best indicator for dependence to the drug nicotine is, how soon do you have your first cigarette of the day? If it's within 30 minutes of waking, they're probably nicotine dependent because their blood levels have dropped overnight and they're hanging out for a cigarette in the morning. So that's the simplest and best key indicator, and that's one question I recommend and the guidelines recommend. If it's within 5 minutes, they're probably highly dependent. Cigarettes per day is a rough guide, but it varies with smoking intensity, how they smoke those cigarettes. People compensate and smoke in different ways and often under-report their cigarette intake. So that's a guide, but only a rough one. If they've had cravings or withdrawals before, they're probably nicotine dependent. So that's an indication that they have had withdrawals from nicotine and therefore are likely to be dependent. The advised part of the 5As is to advise people to quit. And the important message here needs to be non-confrontational. It's put in a way like this, that the best thing you can do for your health is to quit smoking. I'm really concerned it's affecting your asthma, or it does seem to be having an effect on your child's health, or something along those lines. So personalising it, not telling them what to do, not being confrontational or judgmental, but saying, look, as your practice, as your nurse, as your health professional, I really think this would be a wise thing to consider. So that's more likely to get a positive response and less likely to get a hostile response. Having worked out what category the patient's in terms of readiness to quit, then we offer interventions based on that category. So if someone has said, look, I'm not interested in quitting, you're not going to get very far. But it's still worth, with their permission, discussing some of the benefits of quitting and some of the risks of smoking, just to raise the issues to get them to think about it. You can offer them information and then invite them back when they're ready to quit. So they know they can always come back and speak to you. The second group are the unsure group, who are ambivalent about their smoking. So this group are sort of weighing up the pros and cons. You know, on the one hand, there's these reasons to smoke, and on the other hand, there's concerns, just not sure what to do. And you can motivate them with motivational interviewing, which is a skill we use to motivate people to make a lifestyle change. And I'll come back to that in a moment. Often in this group, they would quit, but for certain barriers. So they may be worried about weight gain, how am I going to cope with stress, peer pressure, a fear of failure, and withdrawal symptoms. And if you can address those issues, and there's information about those in the guidelines, often that will then move them on to the next stage. Written information, and please come back and talk to me if you ever want to discuss it. Motivational interviewing is widely used for smoking, alcohol and other lifestyle changes. And it's all about eliciting from the patient their concerns about the habit and their reasons to change the habit. So you'd say to them, well, what do you like about smoking? What are the good things? Then you might say, well, what are the things you don't like about smoking? And then you'll say, well, so on the one hand you're telling me you like the taste and it's good with a drink, but on the other hand your father had lung cancer and you're getting a cough and a friend died recently from a heart attack. So where does that leave you now? So it's basically giving autonomy to the patient. They decide whether to move forward. So it's a very useful, empowering strategy for patients where they often go away and think about it and think, yeah, I'm doing this, but really all these reasons tell me not to, and I'm only getting this benefit, and they sit with that discrepancy and may move on to make a change. And finally, the Ready group. With this group, who are ready right now, we'll set a quit date. We'll talk about their smoking triggers. That's an important part of changing behaviour. So you'll say, well, okay, you smoke after a meal. How are you going to cope with that cigarette? In future, instead of sitting there feeling like a cigarette, you'll get up and go and clean your teeth. You'll go for a walk. And you've got to change that whole situation so they're not hanging out for a cigarette after a meal. We talk about the barriers we discussed earlier, like weight gain. Some lifestyle changes are important. Exercise really helps. They have to reduce caffeine and alcohol, social support, getting friends on side. We give them written information. You can refer them to the quit line for more information. You can refer them to a tobacco treatment specialist, and we use pharmacotherapy. There are three main lines of pharmacotherapy: nicotine replacement, varenicline, which is Champix, and Zyban, which is bupropion. They all reduce cravings and withdrawals. They roughly double success rates, and they're all on the PBS except for the gum, lozenge, inhaler, and mouth spray. So nearly all smokers should be on some form of pharmacotherapy to address the addiction. Oop, wrong one. Okay. And then we arrange follow-up. Clearly we ask them to come back, discuss their problems, talk about their therapy, and try and prevent them from relapsing. On your tables there's a single page of two-sided an algorithm, and it has on one side, first side, it talks about how do you tell whether someone needs pharmacotherapy. They don't all, but most do. And then there's an algorithm to select which medication to give to each patient. On the other side, there's some guidelines for pharmacotherapy for specific groups. For example, can you use NRT in pregnancy, nicotine replacement therapy? Can you give Champix to smokers with mental health problems? Specific issues like that. And again, you can download these from the website that's listed there. Finally, if you thought this was fun and you'd like to learn some more, I strongly suggest you join the Australian Association of Smoking Cessation Professionals. This is a wonderful organisation, which I just happen to be involved with. We have a monthly webinar where you get a monthly talk you can watch and participate in on your computer. An e-newsletter with a tip of the month, paper of the month, training courses, lots of information. A fantastic website which has clinical papers and endorsed training courses and news and all sorts of stuff. We have a journal, a peer-reviewed journal, which is of international standard, which was full of practical articles about quitting. You get a certificate and a window decal to go on your window to let people know that you have these skills. And we have conferences and wonderful networking opportunities. And I have one slide to go. Getting nervous looks from Stuart. Just wanted to do another little promotion for a conference that we're running in November. This is a wonderful opportunity to upgrade skills. Now, this is not a high-powered conference about receptors in rat brains. This is actually a practical conference for clinicians, nurses, doctors, pharmacists who want to learn practical skills to help smokers quit. And there are four main themes, which are mental illness, indigenous smoking, smoking in pregnancy and adolescent smoking, but we're covering the whole range of smoking. We've got 5 international speakers, again, who'll be talking at our level as practitioners, and there will be lectures, workshops, posters and so on, and then a website there for more information. So I hope some of you will come along to that, because I really think this is a wonderful opportunity for practice nurses. You can really make a difference to patients' health and well-being and take the load off the doctors who unfortunately don't have the time. And I really would strongly suggest that you work in partnership with your doctors, maybe set up smoking clinics, but together, work together and speak to the doctor about, in your practice, about coming to one of coming to the conference. And we have a lot of practice nurses in our association, and joining the association to learn more skills. So thank you very much.